My name's Geoff Mulgan. I will chair our session, which will be a brisk hour, looking at the question of transferability. This is one of a series we've been doing on innovations in making evidence useful. Some of you may have seen the earlier ones on generative AI and evidence synthesis, having to do rapid evidence reviews. The last one was on systems maps, and we have future ones lined up on issues such as use of evidence in crisis and fast-paced policy environments. We've got fantastic speakers ahead of you. David Halpern from Behavioural Insights team and many other things. Robyn Mildon from CEI in Australia, currently in Singapore. Kneale from the EPPI Centre, who we work very closely with on evidence syntheses. And we'll have plenty of time, I hope, at the end for comments or questions. Do please also use the chat function to either put in suggested links or comments or facts or questions as well. The last series of these seminars, the chat function on its own was an extremely rich resource, and we then share it with everyone who's taken part, as well as putting the whole thing, which is being recorded now, onto YouTube. So don't say anything you might regret seeing in the public domain afterwards. I wrote a little paper sort of prior to this session, and we'll speak first, and I will rigorously chair myself so I don't overrun, but that will hopefully provide a little bit of framing. And in a way, the sort of question we're looking at is, I think, a very universal one, which is how to understand transferability in lots of different contexts, which is an issue for a company. If you're McDonald's opening, chains in new parts of the world, it's relevant to you. If you're organizing a new religion, you've got to decide how much you tailor that to different local contexts. It's relevant to professions such as medicine, or to teachers thinking about a new teaching method, and is relevant to pretty much every government in the world, which is likely to be trying to learn from and copy others, though they don't always do so. And it's at the core of, in a way, our work on evidence synthesis is trying to understand that if something works somewhere, will it work everywhere, or how do you adapt it? So very quickly, I started from the paper with the two, in a sense, polar positions, which you still hear quite often. On the one hand, slightly caricaturing the comment from Bill Clinton, who said everything, or nearly everything, has been solved somewhere. You just need to basically copy it and scale it up, and then you've solved the world's problems. That's still a very commonly held view. And it implies sometimes that you only need to do research in one place, or an RCT in one place, to tell you what will work everywhere. And the contrary view, which is that everything is local, contextual, socially determined, and there's almost nothing we can draw from experiences of other places. And that's quite a common position in much of social science. In the paper, I show why both positions are not really plausible. There are many examples of very well evidenced programs which didn't quite transfer. Family nurse partnership turned into nurse family partnership is an interesting example of quite complex patterns of evaluation from its adoption in other countries, from the origins in the US to the Netherlands and the UK. And a very prominent example is microcredit methods of the kind Mohammed Yunus pioneered with Grameen Bank, which did spread quite well to some places and not at all to others. And all of these many experiences are cautions against the naive view that evidence from one place constitutes evidence for everywhere. Against the contrary view that everything is local and contextual, there are huge numbers of things which have spread in very surprising ways, from, well, maybe not surprising that vaccines tend to work in very different environments, or Google search engines, or ChatGPT, all the way through to things like parliamentary democracy, which was widely believed to be impossible in countries like India or Taiwan only a generation or two ago, to the spread of things like Western classical music in China right now, to acupuncture all over the world. And there are also kind of more ambiguous examples like anti-obesity strategies, which have some common elements in many places, but also lots of context as well. So in a way, this is key to making sense of the huge explosion of evidence methods, which has happened in the last few years, all of which are premised on the idea you can learn something more generalizable from any kind of study or control trial or experiment, but exactly what is the issue. And the last few years have seen, I think, more sophistication on this, a realization that even medical RCTs are much less straightforward than might have been expected, partly because they've often been done on particular population groups and then applied to others. And the whole, it's almost crisis in psychology, one aspect of which is the problem of so much psychological research being done on what Joseph Henrich calls weird people, Western educated, industrialized, rich democracies, are not necessarily applying to others. So clearly many things do work somewhere, many things work in many places, but not many things work everywhere in the same way. So in the paper, I look briefly at many of the different frameworks which have tried to bring some method to transferability. And I show, and Dylan, who's speaking later, is part of an author of a very good paper on this, these are surprisingly unused in practice and probably unusable, or many of them, in practice because they are over elaborate, over complex, and actually don't get to the heart of the thing being transferred. I look at some other ways of thinking about this whole topic in relation to the dynamics of effective supply and effective demand. Effective supply does mean there is a version of the idea which has been evidenced, and demand means there's someone willing to pay for it and adopt it. And there's an interesting set of frameworks about dimensionality, which in some ways is very intuitive, that how easily any idea transfers depends on how many other things need to change. If you need new roles, new skills, new cultures, then it's not surprising it's going to be difficult. If you can slot it into an existing thing like a maths curriculum in a primary school, then it will be a lot easier. And I talk a bit about the issue of adoption, which is a very important one for the UK, where there's been vastly more effort over the years on innovation at the frontiers of technology and business, and much less attention to adoption of ideas within the economy, and yet this seems to be a key to low productivity. And the Business Basics program was quite an interesting and unusual experiment 3 or 4 years ago, testing out methods of adoption to small and medium-sized businesses and using rigorous experimental methods to find out what worked in adoption. Surprisingly, there are surprisingly few examples of that in public services, and yet understanding the dynamics of adoption is as important as generating evidence on the new methods in the first place. So I try and conclude with some maybe rather obvious questions to ask of any method or idea if you're thinking of transferring it. Has it already spread to different contexts or not? Has it just got one place where it's worked? Do we know what the real essentials are? And Robyn will talk a bit about this later. Ease. We're all of us lazy, so things have to be easy to adopt and adapt, or they probably won't be. And this issue of relevance, how relevant actually is the place where the evidence comes from to the place where it's being applied. And very finally, I suggest some institutional things which could be done to make this whole process work better. Institutionalizing demand pull. I would say every agency, every ministry should have at least someone whose job it is to be hungry, scanning for ideas, options to bring in. Most don't have anyone in that role. There's the formalization of really the supply push, the promotion, the marketing, the use of fashion to promote ideas, which is very much part of the reality, although social scientists are usually a bit sniffy about it. There's embedding into training. Medicine does this pretty well. Almost every other profession doesn't do it, hardly does it at all. And finally, learning some lessons about how to experiment with adoption rather than assuming it happens automatically. So applying the best evidence and experimental methods to the question of how ideas spread, adapt, and are adopted. So I will stop there. I hope that's a bit of a warm-up and hand over to David, who's lived and breathed all of these questions for many years. David Halpern, over to you.
Okay, so like I could do examples. I'm sorry, I haven't got the slide to show you immediately. That's rather surreal. We thought with the Behavioural Insights team, for those who don't know it, is this weird thing that was built in Downing Street more than a decade ago now, as to whether behavioural interventions might work better in policy. So seems like a good idea to have a sophisticated account of what actually drives human behaviour and therefore the policy implications. We were ourselves very unsure as to whether it would even translate into the UK context. Essentially North American work, particularly experiments done on small numbers of Harvard students. Why would that work in Britain, let alone anywhere else? And we found some pretty strong results. So for example, an early famous study, which I'll refer back to in a minute, but is the tax work, which we did early on, by saying to people, most people pay their tax on time. Are people more likely to pay? And we found that they were. We were soon asked by other governments, since we were getting quite good results, at least some, Geoff's exactly right, most governments don't have that kind of scan functions, but at least a few do, like Singapore, and they turn up on your doorstep and they say, that's pretty interesting, can you tell us about it? So we then were asked to try and elsewhere. So if I take the tax work, we were asked by basically the UN and some other funders to see, could we take it to Latin America? We had no idea if it would work or not, so we tried doing a similar sort of thing, about most people pay their tax on time in a place where that might not be true in the same level, which was Guatemala. And we set up a trial with an RCT, and we said, well, actually was sort of 62% of people pay their tax on time, which is very low compared to the UK or US, but still, it worked really well. It worked much better than we thought. In fact, the effect size, if anything, was larger. It was so surprised that the majority of people pay their tax in that context. It led to higher payment rates without further context. And we similarly have found that being possible to spread to many other countries, Indonesia, etc. Some of these techniques appear to be spreadable. So that was interesting. It wasn't obvious that it would be true, but that was certainly seemed to play out that way. Another more ambitious program in some ways was we did work on getting people back to work, unemployed job seekers, as we would call them. And we ran a randomized controlled trial where we made a number of interventions, so-called kitchen sink. We got rid of some of the paperwork. We prompted people, instead of saying, what did you do last week? Because we're acting like a policeman and saying, what 3 jobs did you look for? To say, well, from a psychological point of view, why don't we ask you about what you're going to do next week? It's called implementation intention. It's been found to work in other domains. Would you get people back to work faster? So we'd say to Geoff, well, what jobs are you looking for? Well, I want to be a professor, or I'm going to help the next prime minister. Okay, how are you going to go? We'd prompt how, when, where are you going to do that? And hey presto, and in the original RCT, we found it got about 5 percentage points, or about 15% increase in the number of people back in work. So a very big effect. We then replicated on a regional basis. It was a slightly smaller effect, but still very, very significant. It's one of those areas we have actually then gone on to do it in other places. So we did a version in Singapore, as is Singapore's way. We got an even bigger effect in Singapore, a really well implemented program. In Australia, a similar effect size. And a couple of years ago, we did it in Moldova, which is a pretty tough environment in lots of ways. The effect size is almost identical to the one we saw in the UK, about 5 percentage points. So we were surprised in some ways that it replicated so well, but it did. And I'll give you one third example before, where does it not work, etc. So antimicrobial resistance, huge issue across the world. Estimated 100 trillion cost by 2050 if we don't get on top of it. One of the issues is overprescription. And so we did an intervention which was getting quite famous in the UK, where we identified the 20% of GPs who most essentially will prescribe more than other doctors, even when you factor in their populations. And so we did a kind of classic intervention. We wrote to them from the chief medical officer, and we said, do you know that you prescribe more than 80% of doctors? Here's some other alternatives you might want to use. And it led to a significant reduction, which we tracked for 6 months, about 4 percentage point or so reduction in the prescription rate. And then when we introduced the control, they reconverged. So it's a beautiful study. The question is, would it work elsewhere? Now, interestingly, the Americans, the White House team, were intrigued by this, and we will, informally would go backwards and forwards. They tried a version of it in the US and it didn't work. It really didn't work at all. I think one of the arguments for that is because I think the financial incentives are different in various kinds of ways in the US context, but I'm just telling you, it didn't work. On the other hand, in Australia, it worked brilliantly. In fact, it worked much better because we were able to, the beta team and over there, we were only doing the reference, the level of the practice, which might be, 2, but it could be 10 GPs and telling them that in general. In the US data, you could do it to an individual GP. And so the effect moves from 4% to sort of more 10 to 12%. So that's very neat. We also did a follow-up in New Zealand, which was even more beautiful in some ways. And we replicated the original result with about a 10 percentage point reduction in the prescription rate. But one of the arguments against it was, well, what happens in different populations, even inside when you go somewhere else? So in New Zealand, you have the white population where you see the majority over-prescription as everywhere else. But in fact, for the Maori population and Islanders, there's under-prescription of antibiotics. And so one of the arguments was always, this is a terrible intervention because if it leads to even less prescription on the most needy, that'll be a problem. So we varied the application so that we gave GPs both feedback about their prescription rates relative to the white population and also showed them specific breakout for the Maori population. So what do we get? We get the 10% reduction in the overprescription of the white population, but we see no reduction on the Maori population. It moves a tiny bit, it's not significant, but it certainly doesn't go down. It's just the key detail. So these are actually quite a nice example of where you see sometimes it replicates, sometimes it doesn't. I'm aware of time, but I'll just make some general comments about one of the things about BIT, and as Geoff will know, and we work together a bit on it, is the whole what works agenda. Even if you didn't care about behavioral science, that basic idea of, well, what does work and would it transfer? It's a pretty good one to keep pushing on. And we built a whole series of institutions in the UK, some of which are cross-national now, about what works. But that includes exactly the cycle which Geoff talked about, the original generation. Can you prove it? Can you collate that evidence and put it together? But even that is not enough. And you have to really work on the adoption side, which I'm sure Robyn will talk much more about. But just quickly, are there, why don't things transfer? And just very quickly rattle from what we know in that kind of area. So even within countries, things often don't transfer. And an early intervention doesn't translate. And Steve Aos, one of the great originators of the kind of what works approach, as an economist, he would routinely discount an intervention which was done by an originator by 30 to 50%. So if Geoff comes along with this amazing, fantastic intervention, but he did it himself, well, maybe David or Robyn won't be able to do it because there's something about Geoff. So you should just automatically discount it. And maybe also Geoff kind of really wanted it to work and maybe push the numbers here and there. Sure, it wouldn't. But so there's that kind of issue. A really important technical issue is the control group often is very, very different. So nurse-family partnership is a famous one. Maybe I'll return to it at the very end, but where David Olds get these remarkable results in the US for these early years intervention. When we bring it to the UK, we did a big trial, the control group, gets a lot of visits. They don't get no visits. So you got a lot going on there, including a dosage effect and the comparisons. And that appears to be a key part of some of the difference in that situation. Of course, the system can fundamentally be different. So very famous example in behavioral science is auto enrollment for pensions. With 10 million extra signed up in Britain within a few years, now circa 90% of eligible workers. It's, a lot of discussion, 401k is similar, but in a lot of systems, they would just look at you stupid, like, what do you mean auto enrollment? We just automatically mandate it, or we have a pension system which runs on a different basis. It doesn't fit the nature of the problem in the different system. So some of that just obviously just won't transfer for some kind of palpable reasons. And then, as Geoff said, there's this very interesting question, certainly around the world of psychology, about weird, and maybe there's some deep reasons why some things wouldn't transfer. That's certainly true in some parts of the criminal justice system, but to date, it's slightly been the dog that hasn't barked. And it's not obvious to what extent that is because we haven't really tried to do this full on, or to what extent does it kick in and does it not? And I think the answer is we don't know fully. It'd be very surprising to me, as I said, examples such as criminal justice system, that weird psychology is so big a part of it that you'd have big transfer issues. But maybe in other areas like the three I've given you, the transfer has been less problematic than we thought. So finally, just kind of drawing to a close, think nurse-family partnership is really, really interesting, actually, because of the issue, and Geoff picks it up. I just at least make one point, is that sometimes it really takes a while to even figure it out, because it's not a simple matter. And it's an interesting one, which literally sits in the sort of slightly grey territory for the UK at the moment. Geoff mentioned the Netherlands had a pretty good effect size in terms of reduced abuse and so on with kids. The UK data, the initial 2-year was, pretty much nothing to be seen. At 6-7 years, it looks like there are some effects, but they're not on some of the primary ones around abuse. It looks no difference. We are seeing it on some educational outcomes, particularly reading and writing, but the effects are relatively modest. And if you read the papers in detail, they actually hinge on some corrections to do with month of birth. And so that might be right, or is it a little bit whiff of p-hacking, a tiny bit in there? Everybody really wants it to work. So it's open question. We'll wait to see, but do we have to wait? Some of the biggest outcomes on nurse-family partnership or family-nurse partnership were age 15 and 19. So, it's a tough gig, this, actually, to make sure actually we're even clear as to whether we've got a replication or not. So big issue. And my last remark, which Geoff knows about, but I'll at least mention to people on the call, we're involved in active work right now, at least on the what works side, which is what is exactly as Geoff has been pushing, and Robyn. How can we improve the kind of machinery, the institutional machinery, to improve that lateral learning, those common evidence goods, certainly through the Anglo-Saxon nations, but ideally well beyond. There are surely at least some no-brainers. Even if we've got transfer issues, if you're sat in the president's office or a prime minister's office, a pretty obvious question is, well, what did work somewhere else, guys? Can someone give us that list? And the answer shouldn't be, we'll come back to you in 2 years' time. Can we have some live resources which do that? And anybody who's interested in that, do get in touch. We think it's a really, really important area to progress. Thank you.
Thank you very much, David. You didn't need your slides at all. You covered a huge amount of ground, and that's a good note on which to end. And I hope we can come back to that before the end of this session. Robyn, hopefully you are still awake in Singapore with us. Robyn runs the Centre for Evidence and Implementation, and you also live and breathe all of this stuff. So talk to us.
And just to make everyone feel even more sorry for me, I did tell Geoff I thought I was going to be in Singapore tonight for this, but I have to be in Melbourne. So this is midnight, and this is how good this is going to be, right? So I'm putting the boys to shame right now. Yeah, it's not that impressive. This is workaholic. So I just want to come in behind some things that David said and then add some things. I think David, I think you're referencing the living evidence work that you're involved in. Is that right? That is an absolute game changer. So I don't want to underestimate what David's talking about there. That is a global group of people working to make evidence easier and quicker to use and update. So I really encourage people to ask David about that more, because I think that's going to even change this conversation in a year. Scaling. I have a slightly different perspective on the nurse-family partnership example, and then I'll talk a little bit about how we think about scaling. And this is mainly influenced a bit like Geoff and David's work of the global work we do, but because we do less trials and more taking evidence from trials and trying to make them work in practice, I have a complementary but slightly different approach. Nurse-family partnerships, the effect sizes, David's right, they're small. And I think one thing that needs to be understood when we try and translate evidence across different countries, even whether they be Western or other, is helping people understand the size of the effect. And I think our read in the global South of what happened with nurse-family partnerships is it's difficult to take something from the US, and I hope this doesn't offend anyone, whose business as usual isn't great compared to the UK, compared to, for sure, Scandinavia, compared to Australia, compared to New Zealand, compared to Singapore, compared to... The effect sizes are often going to be better in the US. So it's not comparing the same with the same. So the transportability of some of these interventions built for one particular system they won't transfer to another system. And it doesn't mean that innovation isn't important and didn't work. It's just, it's not built for the same system. And so that brings me to context and systems and why that really, really matters in scaling, and why it really, really matters to be thinking through. I mean, our goal globally is to benefit from things that are trialed and be able to take them to other places. But context, systems, people will always force some sort of adaptation. And it will always force some sort of complexity that we couldn't plan for in the other setting. So David's points are excellent in the work that BIT do in moving things across countries. But sometimes if it doesn't work, we have to really look at what needs to be adapted. What do we need to do for the local people? What do we need to do? And I did a talk today on mental health, and there was a couple of things I was thinking about ahead of this. One was few innovations, when they're tried in a place, come from a systems point of view. So he's actually on the phone, Geoff. I don't know what to do with him. He's literally on the phone with no camera off. Luckily, we're really good friends. So few innovations or interventions or approaches we try and do take a systems approach from the beginning. And few think about implementation from the start. So CEI's work in the UK in particular has influenced some of our thinking around scaling, where we've been asked to come in to look at whether or not interventions or innovations are scalable after they've been through numerous trials. And they often aren't. That's because they're too expensive, nobody wanted them, and they don't fit with the system that they were sort of designed for the thing they were meant to do, not for the place they were meant to be implemented in. And so you get to the whole concept, and David's heard me talk about this, research waste. So we can do multiple trials and get something that's quite good, but it's not going to fit anywhere where we want to go. So Jacob's Foundation, who we're working with quite closely at the moment around education innovations globally, most of what they've been funding, honestly, apart from the kind of tech startup, aren't scalable. And it's not that it means it doesn't work. It's just, it doesn't fit. David Chambers, who's this wonderful man, he's an implementation scientist at the National Institute for Cancer. He came up with this implementation scientist, and again, David and Geoff have given me feedback on this before. We come up with stupid names for frameworks. This isn't my fault, but he calls it the dynamic sustainability framework or some rubbish. So nobody likes it, nobody wants to use it, but I call it the 3 eggs. And what this thing tries to do is help you understand the fit between the what, the place the what's going to be implemented, and the broader system. And you have to find the fit. And when we're talking about transferability or scaling, unless you try and find the fit, there's very little evidence that we can benefit from things across places, no matter how simple they are, and no matter how compelling the idea is. So there's one around thinking about innovations from a systems point of view from the start. There's another around diversity of sample. A lot of the things that are tried and tested, if you look at the samples, the sort of the people that they're tested on, they aren't as diverse as they need to be for scaling, essentially. So it tends to be a similar sort of cohort, tends to be a similar sort of group. And so we wonder sometimes when things don't kind of jump from one place to another in the same way they worked in the first place, whether it's a sample size effect, whether it's a people effect, whether it's a diversity effect. And again, I was in a live example today where a lot of the lived and living experience people around mental health were talking about the lack of themselves in the big trials that we were trying to transfer down in Australia, which hardly any work when we bring them down here for Australia, for New Zealand, even for Singapore, David. There's a real struggle we've got with getting some sort of effect, not around a population effect, but just needing to allow some adaptation, some flexibility to what we're doing. And David knows this, the need for us to really carefully attend to context. And when I'm talking about context, I'm saying the inner context of the setting in which it's going to be delivered, the outer context in which influences how things are going to be delivered. So I'm talking about funding, policies, that kind of outer system, messy stuff, the characteristics of the innovation itself, and the implementation process. So if the implementation process and how that's attended to is poor, that is, we use a spray and pray technique. We just try and train people and leave them to it. Doesn't work. Doesn't work, has shown in multiple studies. Just it's a waste of money and a waste of time. If we don't think through novel implementation strategies that we haven't tried in the common countries, so we think of BRAC and the great work they do in Bangladesh. That's the most innovative implementation strategies I've ever seen, because they have no choice. Whereas in some high-income countries, we almost have too much choice, right? So thinking through how context plays a part, inner and outer, and how the focus on the how, in addition to the what, but almost more on the how, and how that can pay off, would support scaling and transferability. So I think I'll stop there, because I could get, I want to hear a little bit about what poor you, Dylan, are going to say, and then I can wrestle with the two of them on it. But
fantastic. Thank you so much, Robyn. And another very nuanced presentation. I'm glad you got into these questions of simplicity, system, complexity, which I tried, and assembly. I tried covering a little bit in the paper. But they are difficult, and being in an engineering department, how always is treated as just as important as what in engineering. Exactly. But weirdly, in evidence and policy, often people are much more interested in what than how. So exactly. Dylan, final word to you, and please, everyone on the call, do use the chat. Say if you've strongly disagree with something Robyn just said, or how she said it, please say.
And Jonathan, come on, I can see Jonathan. There's some people I know who aren't afraid of telling me. So
we've got a lot of knowledge sitting quietly at the moment, so I may even pick on some of you later. But first I'm going to pick on Dylan. Over to you.
Okay, so I'm just going to have a quick word, I guess, around transferability from the perspective of the Epicenter. And we do a lot of work around trying to synthesize evidence around complex social interventions and trying to understand patterns of research use as well. So we do run into this issue of transferability very frequently. So we're systematic reviews, we're trying to synthesize evidence globally. So we're running into transferability issues. And we see that this issue is important for two main reasons, I guess. Firstly, because the possibility that an intervention is adopted that's either ineffective or potentially harmful. So we want to support effective decision-making. But also we find that where evidence isn't able to demonstrate its salience to particular contexts, it leads to issues around research waste that were touched upon earlier. And this is a field that is where there's several different terms floating around for similar concepts, and it can be quite useful to try and separate them out. And so work by Wang and colleagues, they're quite a useful kind of basis for us and kind of shaping our thinking around separating the applicability question around whether the intervention could be implemented in a particular setting and the transferability question around whether we'd see the same effect. And we think to address both, we actually need an understanding of how the intervention is expected to work, and then also crucially to have an understanding of context, as Robyn was just saying, and particularly around kind of conditions of usual care. And we think that usual care in particular is neglected in the conversations around transferability. And just to emphasize really that where we don't see evidence as being able to have that kind of local salience, when we speak to decision makers, it's a real kind of crucial determinant of whether they use our evidence or not. When we go out to decision makers about our systematic reviews and ask them how they use the evidence, a key determinant is whether the evidence is locally salient. You can see the quote there, kind of competing demands, if you like, around, or competing offers around evidence. You've got something like nice guidance, which is kind of generalized evidence versus local evidence that's got local salience. And then the decision is always to go with the evidence with local salience. And if evidence can't establish its local salience, there is also a competing tendency to go with anecdote. So it really undermines the whole evidence ecosystem if we're not addressing some of the kind of transferability issues. So in the epicenter, I know rushing through them so that we have time to discuss, but in the epicenter, some of the things that we're doing to try to address issues around transferability. First kind of big area is around working with different stakeholders and recognizing that different stakeholders hold different types of knowledge that is useful to try to think about the transferability of an intervention to a particular context. And even from that kind of question of is that intervention needed within a particular context, and just touching on kind of considering issues of usual care, for example, it's through co-production that we're able to kind of understand the systems in which evidence is to be applied often. So there's a range of methods that we're adopting from co-production where there's a kind of total shared emphasis on decision-making, shared decision-making, through to kind of more light touch approaches. The next thing that we're doing is we're trying to use more practical tools for theorizing what's going to happen, and we're building a bank of examples in the epicenter where we're co-producing logic models, and we're distinguishing between logic models that have more of a process logic model, where it's about unpacking what happens in the intervention, as well as more systems-based logic model, where we're thinking about what happens when we embed a complex intervention within a broader complex system. And we use logic models to try and practically theorize what's going to happen, and then to kind of design the review around the logic model. We're also making use of more established synthesis approaches, so forms of qualitative evidence synthesis, for example. Our work with IPPO, we often look at realist synthesis, really trying to understand what works for who, under what circumstances, where context is a kind of key component of that question, as well as more kind of standard quantitative evidence synthesis methods as well, that try to unpack the relationship between interventions and the context in which they're implemented. But we're also trying to implement new approaches as well. And some of the new approaches that we're taking on and we're developing are here. So the first one is around intervention component analysis. So what we tend to find in trial reports is that the context of implementation isn't formally reported. It tends to be scattered across the paper. But where we do find kind of nuggets that help to unpack the relationship between an intervention and its context is in places like the discussion. So we're developing methods around synthesizing these reflections on what underpins the success of an intervention. So an example here is where we looked at interventions around vaccinating flu vaccinations for healthcare workers. And it was through the intervention component analysis approach that we were able to see that there was a difference in the culture of implementation, that where hospitals had more of a leading from the front culture, and kind of leaders being there, sometimes taking a vaccination publicly, for example, leading that intervention from the front, were much more effective than interventions where there was a more authoritarian or kind of dictatorial hospital culture. Similarly, we've got qualitative comparative analysis, QCA, and here we're trying to develop more complex recipes about how interventions respond to context. What are the kind of interactions between intervention components and context that can determine whether an intervention or how an intervention might be transferable. So, for example, same review where we were looking at vaccination programs, we saw that actually it wasn't just a culture of leading from the front, it was also a culture where there had been pre-existing efforts to increase flu vaccination in a hospital. So it was both conditions needed to be present in order for the intervention to be successful. We're also developing new approaches around recalibration as well. So when we develop a meta-analysis, that's a global estimate around the effectiveness of an intervention. In recalibration, we're upward or downwardly weighting studies based on their similarity to where we want to actually apply the evidence. So hopefully to get a better estimate of the transferability of an intervention. But in all of our work, we're facing a lot of challenges. So kind of first challenge is the absence of process evaluation, that kind of evaluation of what exactly happens when we implement an intervention or a policy. And then we've got poor and inconsistent reporting of context to help determine decisions around transferability. As Geoff mentioned as well, we've also done some work looking at frameworks. We're not big fans of frameworks, and I think one of the reasons is that they help to spot differences, but actually they don't help people to theorize if those differences are important or meaningful in the decision around transferability. So you can see spot the difference here. They're both pictures of somebody icing a cake, but actually you could focus in on the differences without them being important. It doesn't change that underlying meaning of what the picture actually tells you. And then finally, finally, just to kind of think about what might help our work further around this area, more recognition around that generalizability, transferability is multifaceted, and it involves unpacking a lot of different questions, investment in developing new methods, and is it investment in established approaches. So for example, co-production, really important, we think, in helping to understand the transferability of evidence, but is often under resourced by funders, really. We also think there's room for greater theorizing, better reporting of context, and crucially from our perspective, greater theorizing around how the evidence is to be used. How do we think that the evidence we produce could help with a particular challenge? And that also involves more upfront awareness of what the kind of commissioning options and choices are that are there to be made. So for example, it's all well and good finding an intervention that is effective and potentially transferable, but again, if we don't know if that's going to be supported by the decision-making context, it becomes a little bit redundant, I guess. So they were some of the kind of quick whistle-stop tour of the things that we've been thinking about from the epicenter perspective. And I managed to stick to 10 minutes.
Thank you, Dylan. And there's a page of references which we can share afterwards, I hope. That was great. So we've got just a little time left. We've got a few questions in the chat, comments ranging from why is it that most social scientists think almost no transferability is possible, to the virtues of realist approaches, use of some community collective intelligence. I'd like to throw it, well, David and Robyn, to kick us off. Really a question of what could be done systematically to make us better at this stuff. And you've given quite a few possible answers. and I'll slightly caricature them, and then maybe ask you to sort of choose where you think the key areas of action are. So one is just training more people to do the kind of very detailed, very nuanced analysis which you presented of particular examples. That is a highly skilled activity, understanding context, effect sizes, etc. Is that the key? Secondly, is the key actually the absorptive capacity of the end users, the policymakers, the teachers, the doctors, the police? Is that where the bottleneck is? Very busy people who don't have time to, go through complex assessments. Is there a diagnosis of how different systems do in this respect? A few years ago, I commissioned a data analysis of use of NICE guidelines, where we found amongst GPs, it was wholly local. In fact, most people essentially acted on word of mouth by other GPs in their area, which is actually a simple, very inefficient system of doing transfer, because the people in Plymouth were not that different from people in Newcastle. And does that take you to sometimes more top-down approaches to enforce change of the kind which some argue help the UK, or England at least, do better in the PISA rankings, which came out yesterday? Is the key having better global living evidence maps, repositories, as David said, so at least there's options to draw on which have been digested? Or finally, can we actually automate some of what Dylan was showing, where you actually automate weighting up or down according to relevance of evidence, etc., using LLMs or other things? So there are lots of options, but maybe a quick word first from David, then Robyn, on what can be done? What are the priorities for doing this sort of work better, this difficult, complex work? David, you kick us off.
Yeah, thanks. Robyn, just making sure it's still awake. By the way, it was a call to do.
Oh,
I'm not gonna. Our former Prime Minister is literally on the stand right now. Anyway, yeah, look, I think what I was thinking about it is when you got a program, is it like a car? You could drop your Jeep off somewhere else, as long as you got some petrol, and it'll drive in a road in lots of different places, right? Or is it like a mobile phone that you bring and actually it's not going to work at all because there's no network or anything, right? It's how big is the context effect? I realized I gave some examples, partly because I think it's almost, I wanted to give some sense of positivity of things that can be transferred. And on your list, Geoff, and indeed the question around kind of co-production, when I say, for example, we moved the stuff and we used a similar application in even the simple tax stuff, we did also send a team of people to Guatemala who had to spend weeks with the team to understand what are the letters they send. It's not a literal transfer, actually. It still complies, Geoff, with your, I think, long-standing account, which is you can take inspiration from other places, but it might not literally be a mechanical, like, just it's exactly the same car, the same vehicle. And some of the US programs I think people wrestle with, which are highly manualized, which has some advantages, but sometimes too much rigidity. So we aren't literally doing the same thing. It's very similar. We're looking for similarity, but we're also adapting it into the context, right? On the absorptive capacity and what drives it, I do think an absolutely key one is, because we also see it within countries too, is the frictional cost and difficulty of the adoption. So the examples I've given where we transfer pretty rapidly is that essentially you're bolting it into an existing system to give it a tweak in some variety. It's much more modest than what Robyn is trying to do when she's talking about changing early childcare models, which are potentially much, much more radical. So it's got much lower initiation costs, as long as there's enough understanding of absorptive capacity in the system. And that, as we know, just Geoff knows this result, and Robyn too, I think it's so remarkable, it's worth reflecting on. This recent work from US trials, I mean, our specific interventions with Bloomberg across 60 cities, going back to those places, even 3 to 5 years on, the majority of the interventions which were found to be effective are not being done 3 to 5 years later. And the key variable as to whether they're still working is it was an adaptation of an existing intervention, like literally a letter which was all being sent out as a better version of a letter, versus if it was a new letter, a new process. If it was the latter, the vast majority have dropped away. So forget replication, transferability. It doesn't even persist over time in the same location. And I think that gives us a very sobering reminder of just how difficult it is. I hardly need to tell Robyn, but implementation is bloody hard work to make it work and make it stick over time. But still can be done.
Thank you. At 5-1, Robyn, give us
Yeah. I'm gonna take it away. So it can be done, but we don't give it enough attention. Right. So we run these trials. We go, yeah, worked. And then we do like a bit of a spray and pray. Right. So we go, I'm just gonna like get everyone across this and hope. Dylan, your presentation was fantastic. I'm not sure like reanalyzing the current research though is going to help us think through implementing and scaling. It gets super complicated and it gets quite hard and I love Epicenter and I love, like, I'm all up and all that. So one thing that I've been arguing with David about for ages, and I eventually will win, is once the trials are done, how do we then not see it as the end point, right? But the beginning point to thinking about adaptation. So no matter what I'm hoping most people on this thing tonight understand that there'll have to be some adaptation. There always is. And David's right in that some of the stuff we're trying to do is around mental health, it's early childhood, it's public health. It can get a little bit complex, and it's complex because systems trump programs no matter what we do. Like, that is just a fact. And so it's really trying to think about from the beginning, how do you develop something? And this work we're trying to do with EEF, with BIT as a partner. How do you think about scaling from the beginning, and how do you think about making something more scalable that will work? And I think once we get past the idea of discovery research or trialing research is the end, and that it's only the beginning to a longer process of thinking about how to benefit from that, transfer it, scale it, adapt it, move it for context. And that's really, that's where we should all be talking now. And it is difficult, but it's not impossible, because trialing, you know, as Geoff and David and Dylan, you all know, like, running trials was hard when it was first started. So we've cracked that. BIT is leading the way in how we do that. So now let's kind of move from, so what? You know, so what do we do with it? And how do we benefit from it? And then de-implementation, Geoff, is, we talk about transferability and scaling, but we don't talk about stopping stuff. So stop the things that don't work and replace them with things that could work. And I can see Jonathan on the screen. It's nice to see you. And I can see him asking questions, which I always like. And that's a really good, you know, keep kind of plugging away. Jonathan and I've talked about this quite a bit over time. So I'll stop.
Thank you very much. We've got about 2 minutes left. So if there's any, thank you for everyone who is putting examples in the chat, especially links which people can follow up. If there are other ones in your mind which you think people on this call would benefit from reading or looking at, please put it in the chat now, because we will then circulate after this session to hopefully improve our collective wisdom. Dylan, 1 minute from you. You've already answered one of Jonathan's questions in the chat. Anything you would like to add at this point about really what could be done? What's the priority for making our whole systems of transfer, implementation, etc. work better?
I think there's a lot to unpack with that, but I guess just thinking about some of the points that are coming through, and so I think with the kind of implementation, I would say that kind of implementation reviews are really important, actually, to understand some of the kind of the kind of core ingredients of what kind of gets interventions off the ground. But I also agree with the point around kind of diversity within samples and within kind of context as well. And I think often kind of diversity and heterogeneity is viewed as kind of a bit of a nuisance, and it's noise within the kind of research. And actually, I think it's through unpacking the heterogeneity and studying that kind of heterogeneity and effect, as is how we make decisions about transferability. So I think just from a kind of epicenter perspective, we're quite happy when we come across kind of diversity, heterogeneity within kind of the literature, because that's how we start to get kind of more of the understanding of the kind of context and the relationship with context there. So I don't think I've answered your kind of big question, but there were kind of some reflections, I guess, of what's
yeah, thank you. And I should say Daniel's question in the chat, we probably need an entire session on, which relates to where actually David started off, of particularly international examples and their applicability in UK contexts. So just two final comments from me before we let you get on with your day. I mean, one is, and Robyn sort of alluded to this, I think there is a problem that this sort of work is lower status than the sort of innovation experiment stuff. The practicalities of how an implementation are just not seen as perhaps as sexy, as exciting as doing the more upstream work, and yet it's every bit as important. So maybe we need to adjust or try and influence relative status. And second, I am just constantly struck by the limited, really cognitive space, absorptive capacity of busy people, whether they're in a government ministry or in a hospital or in a school, is dramatically less than often the people like us assume. So even while we're being sophisticated and nuanced in analysis, it's so vital to turn that into easily digestible, absorbable form for people who just don't have the time in their lives for too much friction, too much complexity. And this links perhaps to a very final point. Our next session in this series is about an extreme form of this, which is how to organize evidence in very fast-moving crises, pandemics, financial crashes, natural disasters, when there's even less headspace to review vast piles of literature, and even more tension and pressure to act. So join us in January for that session. Thank you to our speakers. Thank you to everyone on this call. We will keep following this up because this is, in a way, core to our work at IPPO. And hopefully, collectively, we will make these systems work a bit better, and David and others' global ambitions for at least a baseline of shared knowledge about what works and what's transferable. Perhaps that could be organized a bit more systematically in the
Geoff, just let me say, Daniel, hey, there's a really good point you're making there. There's a whole conversation to have just on. So I just wanted to acknowledge this.
Yeah, I agree with that. Thank you all very much. Have a great day. And thanks for joining us.